for today's class. Before I proceed with it, I just wanted, because since the last two classes had been without any of the participants, I did not have either of you joining, right? So I just wanted to check if you guys would follow through the video or if there is any specific concern or topics that you would first maybe want to rediscuss or revisit before we move ahead. Because today is your last class, right? And topic today is it's a pretty simple and straightforward topic. It just as I was saying, it's a lot of facts that you have to munch upon. So if anything that requires us to discuss as far as our understanding, the clarity of our understanding is required, is there anything that we need to revisit? Okay, again, since it's good to see you back in the class, Shamika, is there anything that we would want to go through once again if there's any particular doubt, or else we'll move ahead with the class for with today's class, right? So just allow me 5 minutes. In the meantime, you can follow through this table. So this table very nicely summarize everything that we will be discussing within the next 30 minutes time. I'll just get my setups ready so that there's no glitch in between. Okay. So, now that we understand about all the different effector responses of both your innate immune branch as well as the adaptive immune branch, we have finally come to the point where we understand that what is normal and how the immune cells will normally react to. But if there's anything abnormal, that could be in the direction of an exaggerated immune response, or it could also be in the direction where there is a deficiency of the immune response that we see. Either of these conditions could be harmful to the organism, right? One. Uh, so the first case wherein we have immune compromise, which in itself is exactly resulting from an exaggerated immune response, that is the case where we say that there is a situation of hypersensitivity. There is also a response where we have been reading about the fact that there's a concept of tolerance wherein the body's immune cells have a memory of have a recognition that this is my own cell or own self tissue, whereas the others is my pathogens, right? Where and how this tolerance component was being achieved, if you remember. Shamika, are you with me?
Ma'am, am I audible?
Yes. So do you
Ma'am,
remember,
can you repeat
can
the
you recall?
question?
Can you recall that from where we acquired the concept of tolerance in our body? Like at which stage of, say, the development or at which stage of selection did we mm, get a chance, did the cells get a chance to recognize that this is my self cell and this is something that I have to mount an immune
Ma'am,
response?
in the lymph node, I guess, there only I think that selection and
So what is this concept called, wherein the body recognizes its own cells? Now that we are very close to your exams, I am sure you must be going through all of it.
ma'am, actually, I'm not well, so I have not gone through your previous lectures also and not seeing the
No, so
notes.
this
So,
is not from my previous lecture. This is from the lectures where we have been discussing
ma'am, that
about
I
the.
know that we have discussed this during class.
So there was this concept of immunological tolerance, right? Wherein we also learned about selection, thymic selection. Does that click no? Anyway, so there was a concept of selection which we have discussed, wherein during the process of development, purposefully the immature or the naive B cells and the T cells are subjected towards your own body's antigens, right? So, wherein we had, so the T cells acquire self tolerance by, and also they are self MHC restricted. Both of these processes was happening inside of the thymus. And for your B cells, the process of selection was happening right at the stage of hematopoiesis before they reach the outward circulation. While they are still stationed inside the lymph nodes, the process of selection, so those are selected population. Before they reach the lymph node, they have already undergone selection, wherein any self antigen, if they are presented with, they will not mount an immune response. So this entire phenomena, we called it as the phenomena of immunological tolerance. So if this tolerance is breached because of different possible factors, what results is a situation of autoimmunity. So autoimmunity is auto, as the name suggests, that I have my own cells, which is now instead of helping me, they're going to recognize and mount a response against the self cells, and that is how they are going to cause a harm to my own body. So instead of protecting me because of a because of a malfunctioning or because of the immune response going haywire, I have my immune cells attacking my own body cells. This is known as autoimmunity. So this results from an over exaggerated immune response. This results from my own cells mounting an immune response against my own body. And the last situation wherein there is some sort of deficiency. So as the name deficiency suggests, deficiency means that a sufficient amount of immune response cannot be mounted because of, say, certain cells not being present, or some type of particular antibody maybe not being produced. We will look into that under which all conditions we say that there's an immunodeficiency that is there. So we'll start with the first one, which is hypersensitivity. So if you could take a minute while I was away. So hypersensitivity, they can be of different types. Initial classifications was that what is the time in which the immune response is getting mounted. So if it's like a quick hypersensitivity that has developed with a very, very, very recent encounter with an antigen, it was classified. It used to be classified as early because the response time is less. Or if the response time is in somewhere, say in some days or in multiple hours, then it was classified as delayed type hypersensitive. But in early, so later on, this classification was further refined, and people saw that we have this type 1, 2, and 3. So early type of hypersensitivity, wherein we are saying that the response time is within a couple of hours, they could be they could further be divided into three such subtypes: type 1, type 2, and type 3. And if the delayed type hypersensitivity particularly is at present, current literature will always refer it to as the type 4 hypersensitivity, right? So this was your classical classification, and now people have refined it into 4 different types. We'll come back to the summary table. First, let's just look at all of it individually, one by one. So the first type of hypersensitivity, apart from this, the type 4 hypersensitivity, all of the other types of hypersensitivity, it has an antibody layer in it that participates in the mounting of a hypersensitivity response, right? In IG1, sorry, in type 1, the antibody subtype which is responsible is IgE mediated. So if you recall, while we have also discussed the different types of antibodies, we said that most of the immune responses are being, so the first one to come up was IgM. Then we saw that the class which happens in the direction of IgG, the one that is crossing your barriers of the body, the physical barriers, was IgA. And there we left our discussion that IgE, which is present in very minute quantities in your circulation, those are responsible for mounting the allergic responses that you see, right? So the response of IgE has not got much to do with, say, it's not something that the body really wants, or it's not, the response of IgE is not one that favors your body or favors some sort of immune response. It's not a favorable immune response because mostly what it is doing, it is mediating the allergic responses. And allergy of any sort is more of a harm to your body rather of that being anyway helpful to us, right? So the type 1 hypersensitivity is mediated by IgE antibody, and the response is evident within 1 to 3 hours of your encounter with allergens. So what are allergens now? So any sort of antigen, any sort of non-parasitic antigen, which can lead to a IgE mediated response, those antigens are called as allergens. So anything that can elicit an IgE response is known as allergen, and ideally they are non-parasitic. So they are not something that is coming from your parasites or the pathogens that we usually encounter. Something in the environment is actually leading to this heightened immune response mediated by IgE molecules. Now, how do they bring about that effect? So IgE, again, let's just also try and bring things together. If you remember the structure of antibody, there was a FC region and a variable region, right? This FC region, the name coming from the fragment which was crystallizable upon enzymatic digestion, but also it's roughly, it is also the constant region of your antibody molecule, constant in terms of the sequence. So most of the IgE molecules have a constant FC region, and we have the receptors for these FC region present on certain cells of our body, right? So the phenomena of complement activation, the phenomena of opsonization, we have discussed those things, and those were mediated by the FC region of antibodies of some or other type of some or the other subclass of antibody, right? Now, the FC region of IgE. So, the FC region specific receptors have been found on the mast cells and basophils. So, mast cells and basophils, if you can recall, those are very important players from your innate immune system. Mast cells and basophils, they have certain granules which pack up a lot of lytic enzymes, some sort of vasoactive components, and they're packed inside certain granules. Any sort of signaling that can trigger the degranulation or the release of these granules into the extracellular spaces. So all the active components inside these granules can also come up into the extracellular spaces, and eventually they are going to mediate a downward response, right? So what are the components that are actually getting packed inside the granules? So we have some primary mediators and vasoactive amines. So vasoactive amines, as it says, so vasoactive is something that is having some effect on the blood vessels. And amines, so some monoamines or some diamine molecules, those have a potential of bringing about your smooth muscle contractions, because of which we can have because of which we have the blood vessel musculature. They can show a lot of contractions and relaxation, which is eventually going to help in the overall vascular permeability. And the primary mediators that is being referred here is they can further be of different types. It could be histamines, proteases, eosinophil and neutrophil chemotactic factors. So something chemotactic factors for eosinophils and neutrophils, right? So some chemotactic factors means that they can they can guide these particular cells to come to the site of inflammation. Again, histamine, proteases, we have heparins, we have discussed those things while we have discussed the uh, innate immune responses in our previous classes, right? So we understand by now that these are essentially regulators of your innate immune system. And what do? They mediate or they mount acute inflammatory reaction. Inflammatory reaction means, so there are certain hallmarks of inflammation wherein we have the vascular permeability which is enhanced. We have the smooth muscle contractions happening so that the blood flow can be enhanced. Permeability enhancement also allows for uh, the extravasation of the leukocytes. We have chemotaxis of a lot of active cells. So granulocytes, again, they have a lot of active enzymes packed inside them. So all the granulocytes can come to the site of infection or the site where there is a encounter of an allergen and extravasation, and eventually they will also migrate into the. So if you look here, the important thing to note is that everything that is actually happening is what in a different context was helpful to the body, right? But right now, because the response is so exaggerated, more than any more than these same reactions being helpful to us, the system is actually getting negatively impacted because of the same mechanisms. So the regulation of immune system, so the idea is that we now appreciate that the regulation of an immune system, if this balance is either way disturbed, then we will have a negative consequence that gets ends. right? The mechanisms being the same. So the primary response is that so the initial the first in within 1 to 3 hours of time we have the degranulation and release of the primary mediators and vasoactive amines based because of which an acute inflammatory reaction is happening at the site of an allergen encounter. And further, within the next couple of hours, we will have these same cells that have reached the site of inflammation now producing a lot of secondary mediators. The secondary mediators means there are certain platelet activating factors. There are some arachidonic acid derivatives, prostaglandin, leukotrienes. Again, these are more potent inflammatory molecules, but and they are not initially present, but they come into they are getting synthesized inside the cells once they receive the stimulus for its synthesis. And what is the stimulus for synthesis? It's nothing but the time of exposure of allergens. So the longer the allergen is present, or if there's a subsequent encounter with the allergens, the secondary mediator release is further heightened, right? So eventually we will have a lot of inflammation that is ensued in a localized space, and if that is going to lead to a lot of tissue damage, and the cells of the particular area can experience a lot of damage, and eventually we will have all sort of allergic responses coming up, right? So if we say that we have a skin allergy or something, any sort of allergy, we associate it with, say, to a lot of coughing. If it's a bronchial allergy, if there's a dermatologically related allergy, which is essentially your skin, we see a lot of redness and everything. So I hope we now understand that what responses are mediating those sort of observations that we have always made, right? So there are two stages in which this entire immune response happens. One is your sensitization phase. So what happens in your sensitization phase is, so we have the IgE molecules. So we have a allergen. This allergen is cross-linking the IgE molecules, because of which we will have the eventual immune response, wherein we will have the release of certain chemoreactive factors and all the factors that we have just discussed. And also this allergen gets a chance to get internalized and eventually get presented to your TH cell. So those are again the same responses that we have been studying so far, right? So the sensitization phase is wherein we have these allergen activating your B and T cell arms, and eventually they differentiate into the memory and plasma cells of the respective subtypes. Now in the effective phase, wherein we already have this allergen, it's a second subsequent encounter of the allergen. Now we will have these released IgE molecules binding to the Fc receptors on your mast cells. Because of this binding, we will have degranulation of the mast cells. So these blue dots you see is all the vasoactive amines that have come out. And eventually, because of that, we will see a lot of responses, which are all hallmarks of your uh, inflammation. But if this inflammation is exaggerated in itself, there is going to be tissue damage. The cross-linking of the IgE is an important phenomena which is important for all the downstream signaling that we saw. So for degranulation from the mast cells, it's not just binding of IgE to the Fc receptors that is sufficient. We need this allergen to cross-link two of the antibody molecules, and only then the signal transduction ensues, and because of which we have all the responses from the mast cells coming up. Now we have some examples of the primary and secondary mediators. So essentially, what do they do? What is the function of those? Just a quick read. So it's histamine, heparin, serotonin. Most of them, if you see, is going to do something with the vascular permeability, or it will guide the chemotaxis of certain cells of our interest. And proteases, if you see here, so bronchial mucus secretion, as I was saying, so we experience a lot of coughing. The coughing comes from the fact that there's a lot of mucus secretion happening in the bronchus, and coughing is a response wherein we are trying to clear off the fluid, any fluid that is stuck inside the bronchus, right? So because of that, what underlies that is the mucus secretion that happens because of the primary mediators. Secondary mediators that we also talked about, the platelet activity factor. It is going to, as the name suggests, it's going to cause aggregation of the platelets. Because platelets are going to be required if there is say any breach in the system, there's any blood flow that's happening. So platelets are required for clotting of those responses. But if the same response is exaggerated, it also leads to the degranulation of your vasoactive components from your mast cells and basophils, and eventually inflammatory response is going to follow. Okay, so leukotrienes again mediate vasopermeability, contraction of pulmonary muscles, bradykinins, prostaglandins. So it's a redundant information, and you can like try and remember as much as possible, right? Some of the common allergens have been discussed. So, some proteins that can be present inside the foods, like the foreign serum or some vaccines, they can be an allergen to some of the individuals. There could be some pollens that is also a source of allergen to some individuals. Drugs. So, penicillin, if you see here, very interesting is that this penicillin drug that is, so we have read about it at different intervals, right? Penicillin in itself is a drug that triggers all the four types of hypersensitivity. Despite of it being a useful component, the presence of this drug has a potential of activating either of the hypersensitivities that we are trying to learn about. Okay, so some insect products that could uh, lead to hypersensitivity, some animal hairs and dander. So not everybody is allergic to all of these. So different people only have, because it depends on what is the genetic makeup of that individual, what is the nature of immune response that is being produced from that individual. Based on that, only some individuals, specific population only develop allergies to different sorts of allergens. Not that everybody develops an allergy against any of the components or all the components, right? Okay. So again, this is a schematic representation of what we have been trying to discuss. That there's an early response phase and a late response phase, and they have tried to give you an example of what are the players that are mediating it and what is the eventual consequence of the release of these players. So in the early response phase, the vasculature is somewhat affected. But if you look here in the late response phase, because of the other molecules that have now been introduced, so there's a lot more active recruitment of immune cells. The basement membrane of the vasculature is also further thickened, and we have a lot of active cells of your innate systems, right? Innate immune system, which have crossed the barriers and have reached inside the circulation. So the extravasation property has also been emphasized upon. So now the cytokines, or the active components that are mediating the responses have also been mentioned. Okay. The last thing that is important for hypersensitivity type 1 is that this could be of two types. One is anaphylaxis. So anaphylaxis means that there's a very rapid immune response which could become life-threatening because the entire body experiences some or the other sort of allergy. So when your entire body system, so multiple organs or multiple tissues at the very same time is experiencing an allergic response, that sort of a situation is known as anaphylaxis, which means it's a systemic phenomena. Systemic means anything that has to do with the entire body, entire systemics of the body. All the systems. So the system name systemic comes from the fact that all the systems are affected or compromised. And on the contrary, if we have a more localized sort of allergic response, that phenomena is known as atopy, and usually it has a hereditary basis, right? The hereditary tendency to develop allergic reactions specific to certain target organs or tissues only is known as atopy. So, asthma that we have all heard about and learned about at some or the other instance is a type of atopy reaction. There's also allergic rhinitis. Rhinitis is to do with your nasal septums. So any sort of running nose or watery eyes. So those sort of allergy, any sort of allergy that leads to those sort of symptoms, those are called as allergic rhinitis. And again, atopic dermatitis, as I was saying, is related to your skin allergies. Okay. The second type of hypersensitivity is also called as the antibody mediated cytotoxic hypersensitivity. Now, very well, again, as is also suggested by the name of it, there has to be an antibody molecule that is mediating the response. And what response? The response is cytotoxicity. So it involves your complement protein. So we have learned about the fact that all the different players, the different effector responses that the antibody molecule can bring about. So we now know the importance of antibody in the process of opsonization, complement activation, and also, so we were just discussing about the cross-linking part of it. So if there's cross-linking and all, they can mediate degranulation of your cells which have active components packed inside the granules. And we have also learned about ADCC, which is antibody dependent cell mediated cytotoxicity. So ADCC is something that sounds most relevant because again, the name here is antibody mediated cytotoxic hypersensitivity. So here the important class of antibodies IgM and IgG, which can bind to the antigens of the cells and involved in participation of complement proteins or the cytotoxic cells with Fc receptors. So complement proteins, that component is also involved in this in this process. We have the cytotoxic cells with Fc receptors, so ADCC phenomena is involved, and phagocytes, so opsonization is also involved. So how was antibody contributing towards phagocytosis? Is that if there is an antibody molecule, antibody molecules are coating multiple small, so we can have the different antigens present on a pathogen getting coated by the different types of antibodies, or maybe the same antigen is getting is small in size, and once it is coated by multiple antibody, it becomes a macromolecular complex, or the size of the complex is enhanced. Now, whenever the size of the complex is enhanced, there is an enhanced chance of it being cleared by phagocytosis, and this process is known as opsonization. The antibody, this phenomena wherein the antibody is is in a way enhancing the chances of phagocytosis of an organ, of an antigen. This is known as opsonization. So all the different components, we saw how complement activation can be achieved, how opsonization is achieved, how ADCC is involving, can be activated. So all these different components are involved. Apart from this cross-linking and regranulation, all the different components have a role to play, and that's how the hypersensitivity can be developed. And we can try and understand that using an example. So there are three phenomena which are based on, so the observation of either of these phenomena is because of the underlying fact of antibody mediated cytotoxic hypersensitivity. What all? So the hemolytic disease of the newborn, the blood transfusion reactions that happen, that if you are say transfusing the wrong blood groups without matching them, so the that sort of immune response that comes up, that is also because of type 2 hypersensitivity or hemolytic anemia. So hemolytic anemia, if there is anemia resulting from hemolysis. So hemolysis has to do with the death of your RBCs. Let's just try and understand with one example. This hemolytic disease of the newborn, also known as erythroblastosis fetalis. Erythroblastosis fetalis is, it happens if there is a Rh positive fetus inside of a Rh negative mother. So say if we have a female who is A negative, now has a B positive or any of the positive blood group carrying. So this positive is nothing but the Rh factor that is present on the RBCs, right? So this antigen A, B, or if there's no antigen, or if both A and B antigens are present, so these are nothing but we have the RB. I hope we know this concept that RBCs have a lot of different molecules on its surface, and some of it can also be uh, recognized as an antigen. So if you like put my RBC into some other organism's RBC, other individual with a different blood type, the antigens which are present on the surface of my RBCs is recognized as foreign in the new individual because our blood groups are not matching. So that's how the AB and AB or O blood group typing is happening. Along with that, we have the plus and minus. So there's another antigen, which is RH, the name coming from rhesus, and that's why the RH factor is given. So if we have the RH antigen, the blood type is positive, and if the RH antigen is not present, the blood type is negative. Now, if we have a RH negative mother having a RH positive fetus, in the second pregnancy, there could be a complication which is known as erythroblastosis fetalis. So, what happens essentially when a fetus is growing, we have enough barriers in place. There is no transfusion of blood through the placenta, right? But the antibody molecules can still cross through the placenta. So, once your first pregnancy is there, say the fetus is Rh positive, this pregnancy can be successfully carried out. Why so? Because this barrier of placental barrier that is there, it is not allowing the flow of blood between the two individuals, and because of that, this fetus, which is having this Rh positive antigen, its cells will never reach the maternal circulation. So if there is no antigen that is reaching the circulation, we will not have any sort of immune cells that is getting primed against this antigen, right? But during the time of delivery, when this umbilical cord is breached, right? When we have, so during the time of delivery, there is some sort of blood transfusions that happens because of a breach in this umbilical cord, and some blood along with this Rh positive RBCs, they can reach inside the maternal circulation. Now, the fetus is already out of the mother, but the antigen has reached the maternal circulation, right? Against this antigen, the mother's body is going to produce certain sort of antibodies. And now, if it doesn't has a Rh positive fetus because the pregnancy is already carried to term, those antibodies are not going to get a chance to mount any sort of immune response. But during your second pregnancy, during the second pregnancy, the antibodies can cross. So all the antibodies gets a chance to reach your fetal circulation. Among all the antibodies, the anti-RH antibodies can also reach the fetus, and that is going to harm the fetus. It is going to harm the blood cells of the fetus, and eventually the pregnancy could get aborted because of this function. So this is known as erythroblastosis fetalis. So erythroblastosis, which means that the blood cells of your fetus is getting damaged because of these memory cells producing the anti-RH antibody, which can reach the fetus. And if they reach the fetus, we have the attack on the fetal RBCs, causing the erythroblastosis fetalis. So this response that we just discussed, this is how the type 2 antibody, the type 2 hypersensitivity is mediated. So because of antibody, some sort of cytotoxicity is ensued. Now, this condition can be prevented. There is a way of preventing it. How? That if this anti-RH antibody, if we can neutralize it, if we neutralize this, which means we block the binding of this antibody to the RH, then this entire situation can be prevented. So how do we do it? So this is almost with 100% success. It has been now shown that there's a particular drug which is now called as Rogam. It's nothing but a injection. What is present inside this injection is anti of RH antibody, right? So so RH reach the maternal circulation because against which we have anti-RH antibody produced. Now, if we have Rogam administered, this anti-RH antibody is not going to be produced. Why so? Because Rogam binds here and doesn't allow this to be recognized as a foreign entity. So binding of this, so if I so the now the complex against which we have an antibody response in the mother is this complex Rh bound by an antibody. Whereas in your second pregnancy, what is the antigen that is indeed present is Rh positive. So the mothers, before I have a anti-RH antibody production in the maternal circulation, we are in a way we are neutralizing this Rh antigen itself so that there is no B cell activation that gets a chance to so there's no B cell activation that occurs. So is this is why within 24 to 48 hours of the delivery, Rogam injection must be administered to all the RH negative mothers, so that if eventually they have a second pregnancy where a RH positive fetus has to be carried to term, there is no occurrence of this condition called erythroblastosis fetalis. Anything to discuss so far? Okay.
No, ma'am.
So in type 3 hypersensitivity, this one is called as immune complex mediated hypersensitivity. Again, immune complex. So the most important fact that what is mediating this particular type of hypersensitivity is right there in your name, right? So immune complex mediated hypersensitivity, which means that the persistent antigen antibody complex here is causing the harm. So we have seen that it is important for the clearance of this immune complex to occur. Otherwise, we will have a lot of anaphylactic reactions that can take place. Anaphylaxis, again, something coming from the lectures where we discuss the complement proteins. So, the split products of your complement proteins, right? So, we had the split into a small and a large fragment. Most of the time, the small fragment is going to mediate the processes of anaphylaxis. So anaphylaxis is localized inflammatory responses. Now, if there is persistence of your antigen antibody complex, what happens again? So if there is this antibody, we have its FC region, and this FC region is responsible for mediating most of the biological functions, right? So this FC region can be bound, can get a chance and bind to the FC receptors on our phagocytic cells, and eventually, uh, so we have to identify phagocytic cells, right? So the purpose is that these immune complexes bind to phagocytic cells and eventually get phagocytosed by those phagocytic cells and get cleared off. But if this system doesn't work, there's this persistence of antigen antibody complexes. And if you remember, the persistent antigen antibody complexes can activate the proteins from your complement system. So if there is activation of proteins from complement system, the anaphylotoxins can be produced. So anaphylotoxins means this, so these were nothing but the smaller fragments of your complement proteins. And because of persistent uh, immune complex, production of anaphylotoxin is going to also be persistent in the tissue, and because of which we will have the tissue damage that arises because of the all the lytic components and enzymes that are formed. Now, interestingly, so we do have the toxins that is that is mediating all the localized immune damage of the tissue. But apart from that, at the site of damage, we also see a lot of neutrophils that have come up. So what do they try to do? So neutrophils in this particular position is now trying to attempt phagocytosis of these immune complexes. But if it's not getting a chance to do so, because it's not its usual job to to perform phagocytosis and clear of the immune complexes, in its attempt, it is also producing a lot of lytic enzymes. So again, what was supposed to be a helpful response, that the ISKI intentions were good, that you want to clear the complexes, but that's not its usual job, right? So it fails to do so. And as it fails to do so, it also produces a lot of lytic enzymes. Now, these lytic enzymes, in addition to the anaphylotoxin, is going to further damage the tissue that we see. So, just like your type 1 hypersensitivity, now type 3 hypersensitivity could also be localized or generalized. Generalized, again, which means systemic, right? So, systemic type 3 hypersensitivity is seen in autoimmune diseases or in drug reactions. Again, penicillin administration can also lead to type 3 hypersensitivity development. Or if we have certain infectious agents, say some microbe associated antigens or some other pathogen or some fungi associated antigens, those antigens, if they are persistent, we will have a lot of antibody bound to it. And if this gets not gets cleared, then it can mediate a generalized hypersensitivity. Localized response, localized hypersensitivity can be ensued, such as in the example of an insect bite. So the insect bite happens at a particular point. Because of that, sometimes we see that a lot of rashes around those points have developed out. So what is those rashes? So these are nothing but because the inflammation has occurred because of the anaphylotoxins that have been produced at this point of insect bite. We see all those rashes in a common point, right? Now, or it could be some sort of pulmonary reactions if it's a airborne antigen that is now stuck in your bronchi, say. So it can lead to a lot of pulmonary reactions and a lot of mucus production inside your lungs, leading to a lot of coughing and also all those different reactions could be. So the idea is the mechanisms are the same, but just because something is not getting cleared up in time, or if something is persistent, or if something is cross-linking some sort of other leading to release of certain other active components, because of all those things, what was initially supposed to be helpful is now becoming detrimental to our own cells. So just a schematic of the same thing that we have discussed so far, that if we purposefully administer an antigen, We can have that binding to the anaphylotoxins, these immune complexes. When it is bound by the anaphylotoxin, it can lead to complement activation. The anaphylotoxin eventually produced as a consequence of those complement activation can lead to degranulation from the mast cells, or it can also, the persistent immune complexes can also lead to activation of the neutrophils. And these neutrophils, in an attempt to clear or phagocytose this immune complex, release a lot of lytic enzymes, and that can also damage the site of infection. Okay. So last is your type 4 hypersensitivity. Just give me a minute. So in type 4 hypersensitivity reaction, so this is also known as your delayed type hypersensitivity or cell mediated hypersensitivity. This is the only type of hypersensitivity which doesn't involve an antibody molecule in its responses. There's no involvement of antibody molecules in it. Primarily, the response mediators are your T cells. Among the T cells, it is majorly the Th1 cells, and some of your sometimes your TC cells can also be involved. So Th1 cells, they produce cytokines that accumulate and activate the macrophages. Because of this activation of macrophages, there is a lot of local damage that is happening in your tissue. Now, why is it delayed type? Because your adaptive immune system player, the T cell, is involved. And for activation of your adaptive immune system, it takes a couple of days. So the ideal response time that is noted here is somewhere around 48 hours. So if you have an allergic response that is coming up after around 48 hours of exposure to your initial exposure, so then that means you have a delayed type hypersensitivity that has occurred. How is that occurring? So Th1, so Th cells are going to release cytokines. Because of these cytokines, it will bind and activate the macrophages, and we will have some sort of local damage that can happen. Let's try and understand that how this local damage is happening. So the first phase again is your sensitization phase. Now we can have this, so macrophages are antigen presenting cells. We have a certain intracellular bacteria that has got phagocytosed by the macrophage, and eventually it is going to present it to your Th cells. Now the Th cells, usually it is going to produce certain certain cytokines, but in delayed type hypersensitivity, the Th1 cells, They are going to release the cytokines that is going to enhance the activity or the cytokine release from your macrophages, and they're going to eventually maintain these macrophages in a constitutively active or activated state. Because of that, all the cytokines that come up, we will eventually have the other cells, the cells of your innate immune system coming up, because it's among the cytokines there can be a lot of chemotactic factors that are produced, and because of these chemotactic factor produced, we will have all the cells of an innate immune system reaching the site. Now, essentially, for this sort of response to be stopped, the cytokine response needs to stop. But the cytokine response is not getting terminated because the Th cells are continuously producing cytokines, that is keeping your macrophages in a activated state. So the first phase again is your sensitization phase, where we have the initial encounter by the bacteria that is mediating this hypersensitivity. In this particular example, it's a bacteria that they have taken up. And eventually, when this activated macrophage is again encountering the same sort of bacteria, it is going to produce a lot of cytokines, and it's also going to produce these active components, which in itself can also damage the tissue. So oxygen free radicals and NO. So these are all free radicals that are produced, and free radicals are harmful to your body cells, right? So via cytokines or via production of these active components, your macrophage is going to cause tissue damage in the delayed type hypersensitivity, which is also the type 4 hypersensitivity. Okay. So now coming to autoimmunity. So we just saw that an exaggerated immune response to the foreign antigens, they can be very harmful. At the same time, what can also be very, very harmful is the immune response, the normal immune response, but to my own antigens, right? To my body's own antigens. Now, how is that happening? It could be because of the trigger for autoimmunity can be for either of the four factors. It could be because of a genetic factor, a viral infection, some hormonal changes, or if there is a psychoneuroimmunology, which means some sort of stress or some sort of any sort of changes in your nervous system that is triggering a immune response. So the brain and immune cell axis that getting affected can also lead to result into autoimmune reactions. Now, how? So, if because of any of these four alterations, we can have some change in the gene expression, which directly or indirectly interferes with the regulatory pathways of the immune system. And that is how we can have some sort of autoantibodies coming into the circulation and damaging my own cells of the body. Now, it can further again be classified for ease of our understanding, and they can be classified into four such types. What all types? First, based on the site of involvement. So, like at which point or where this autoimmune reaction is taking place, and the nature of lesion. So, nature of lesion means that what is the damage that is getting caused. So, it could be hemocytolytic, localized, which also translates as organ specific, or it could be systemic. Systemic means non-specific and anything that is happening in the generalized body throughout your body, right? Okay, so look here. This is again a summary of how this can happen, how autoimmune reactions can occur. So first we have T helper cells. And we understand that during the development of T and B cells, we have some antigens that is presented to these developing cells so that they know that this is my own cell. But we do have some cells which are sequestered from the rest of your body, so rest of the circulation of your body. So sequestered means that there are some cells which are some of the antigens which are present in your immunologically privileged site. So immunologically privileged, which means there is some sort of barrier which is not allowing any cell or any sort of antigen present on these cells to reach your circulation and get a chance to get presented to your developing B and T cells. Say, for example, there's a blood-brain barrier that protects the nervous system. There's no diffusion of blood inside your brain. So it's an immunologically privileged site. How? Because if there's no diffusion of blood, we do not have any of the leukocytes inside your blood and inside your vascular circulation reaching the brain. But we do have some resident immune cells present in the brain which can take up which can look into the immune regulation and immunological responses that is happening inside the brain. But as such, none of the antigens that is present. So myelin is there as a covering on all your most of your nervous cells, right? Most of the nerve cells. But this myelin is not presented. It's not because it doesn't get processed and get presented to the developing T cells, for example. So that's how this is despite of it being my own body's protein, my cells, the immune cells of my body doesn't recognize it as my own because they did not encounter it while the development of the T cell is happening. That's one example. Apart from that, also have the cornea. So there's eye cornea. In the eye cornea, we do not have any sort of immune cells reaching there or any sort of antigens of the cornea, which is um, presented to your developing B and T cells, or say the sperm cells. The sperm cells, because again, there's a blood testis barrier, so we do not again have the uh, immune cells of your circulation reaching there or the antigens from the testis reaching the blood. So these are your immunologically privileged sites where there is no cross flow of body fluid. Now, these sequestered antigen, despite of them being my own, if because of say some sort of damage, so maybe there is some damage in the brain because of some head injury or something like that, and we have the blood reaching inside your brain tissue. Now, if the blood reaches the brain tissue, along with the blood, we will have all the immunological cells reaching the brain tissue, and it is going to recognize the sorry. Okay, so I hope you understand now because of this physical breach, because of some sort of traumatic injury or something like that. If now the blood cells encounter your nerve cells, say, which is myelinated, it is going to recognize this myelin as a foreign component and produce antibodies against it. Now, antibodies that are getting produced, so now the body has a memory cell against the myelin. Now, eventually this head traumatic injury heals and everything is fine, everything is sealed back, but still I in my body have some auto antibodies, have a memory cell against this cell of my own body. Now eventually when the antibody is produced against the myelin, it can now reach the brain and damage the nerve cells, and that is how there is so this process is known as release of sequestered antigens. So because of the traumatic injury, these sequestered antigens, some of the examples mentioned here, have now got a chance to get presented to the T cells, and I have memory T cells against these antigens, and eventually if I again encounter it, I am going to cause a super harmful immune response against these cells. So that's one way. The other possible reason for production of autoantibodies could be because of the phenomena where there is molecular mimicry. So, what is molecular mimicry? Now, in an attempt to evade the host immune system, the pathogens are very smart. In the course of evolution, they have they have harnessed some sort of mutations that very closely resembles to my own to the host cell components. Now, how the pathogen benefits out of it? It benefits because of the fact of immune tolerance. The pathogen has now played smart, and it knows that if I look similar to the host cell, the immunological tolerance is going to identify me as the own cell, and it is going to spare me. But it can backfire to the host individual. Why so? So if there is a molecular mimicry, but my immune cells have identified, that this is a mimic and this is not exactly my own cells, it mounts an immune response, and it also preserves a memory of it. But now, if in future my cell component, which was somewhat similar to this infectious agent's mimic molecule, this can by chance also get recognized by the same memory cells which recognized this pathogenic mimic, right? And that's how I will eventually have the autoantibodies produced against my own cell components. So these are fine breaches in the regulatory mechanism that is compromising the overall system. So, antigen presenting cells with cross reacting antigens because of molecular mimicry can also lead to activation of T cells against my self antigens. The other possibility is if there is inappropriate MHC expression on non APCs. So, cells that are usually not antigen presented cells, but because of certain underlying condition or maybe because of some infection or some hormonal changes, I can have these non-APCs expressing MHC molecules, which for an example is the case if there is diabetes, so type 2 diabetes mellitus, wherein your pancreatic islets of Langerhans, in a normal situation, there is not going to be much expression of MHC2 molecules and very, very few MHC1 molecules that is expressed on the surface of these cells. But in case of the islets of Langerhans from your diabetes patient, type 2 diabetic mellitus patient, we see that a lot of cells on this or from these islets of Langerhans, they are now expressing a lot of class 2 MHC molecule, and in this process, it now tries and function as an antigen presenting cells. But it is not its usual job is not to be an APC, right? So it doesn't really know how to do it, and in this process it can present false antigens towards to the T cells, and eventually the T cell is going to because if it is presenting some sort of false antigen, something that the T cell should not have recognized as an antigen, presence is to the T cell. The T cell only knows that this is being present and have to mount a response. The T cell response, which is non-specific against my self antigen, can result because of this sort of inappropriate MHC expression. Right? So cells with higher than normal levels of MHC class 2 can sensitize non-specific T cells. So because of all these things, I can have the activation of T cells, which I did not expect. And this activation is against the self-antigens of my body. Eventually, it will uh, activate activate the macrophages, and it will mediate the inflammation and local delay type hypersensitivity. It can produce some sort of cytokines. It can also switch its classes. It can also cause activation of TC cells, eventually differentiating into the CTLs, again leading to tissue damage. It can also activate the B cells, which leads to the production of plasma cell, differentiation of plasma cells, and eventually antibody against the self antigen is getting produced. And further so, in this process of activation of B cells, instead of this B cell differentiation happening towards plasma cell, which is producing monoclonal antibody, which is normal for the body, I can have the B cell, a faulty B cell population, producing polyclonal antibody. So polyclonal means it is going to produce, the same cell is now producing different types of antibodies. So these are all malfunctions, right? So now because of certain sort of other malfunctions, which could be because of some bacteria or viruses, I can have polyclonal activation. And in polyclonal activation, the chances of production of autoantibody is very high. Because, say, this B cell was intending to produce antibody against the virus A. But some of the antibody that it also produced, it looks like A dash or A double dash. And a chance remains that these could be very much similar to the, so these antibodies can very much recognize the host antigens, and because of which autoantibodies or antibodies against the host cells are getting produced. Okay. So these are the this was exactly the mechanisms that can be mediating the autoimmune responses, and let's just quickly get into the types of autoimmune responses. So hemolytic again, as the name suggests, there's some sort of hemolysis happening, and hemolysis means some lysis of the blood cells. So hemolysis, which is a very noted fact in autoimmune anemias, therein we have the antibody molecule coating the blood cells, most likely the RBCs or some of the important factors which is required for RBC development. They could become the target of the autoantibodies, and because of which the cells are destroyed before it kind of gets a chance to perform its function. Okay, and the example of this case could be pernicious anemia or the hemolytic anemia. So anemia is something wherein we have some sort of iron deficiency, and the iron deficiency could be either because there is a deficiency of iron in the body, or it could also be because the RBC in the body is getting damaged. Because if there's no RBC, there's no so iron that is present, the hemoglobin molecule, which is sequestering all the iron, it is not going to be present, and eventually it manifests in the serological reports as iron deficiency. So pernicious anemia is where there's something called as intrinsic factor, which is also equivalent to, I think, vitamin B12. So intrinsic factor, it is important to be present inside the RBCs, but now if my body is producing autoantibodies against this intrinsic factor, eventually the RBC lysis is going to occur. And because of lysis, it is going to manifest into anemia. So pernicious, this entire disease is called pernicious anemia. So any sort of autoimmune disorder is going to manifest in a one or the other type of disease. So the disease that manifests because of autoantibodies against intrinsic factor is known as pernicious anemia. And if I have autoantibodies against the RBCs, then this is known as leads to the disease of hemolytic anemia, wherein some sort of antibody is going to bind to the antigens on the erythrocytes, the red blood cells, and eventually it is going to damage those RBCs. So, and it will manifest into hemolytic anemia. Now, autoimmune diseases could also be specific or systemic. Specific as in it could be specific to a particular cell or a particular organ. Now, it's a long list of diseases. Eventually, the idea in all of it is that one or the other cell type is becoming a target of the autoantibodies, and eventually, because of the destruction of those particular cell types, I have a disease that is following up. So, some of the common examples being Addison's disease, wherein the Addison's disease, where it is the adrenal cell that gets affected, and we have so if you look here, it is autoantibodies that are mediating these processes. Autoimmune hemolytic anemia, we have discussed. So hemolytic anemia is falling under this first category. We have good pasture syndrome, where the renal and the lung basement membranes become a target of autoantibodies. Graves' disease, where the thyroid stimulating hormone receptor is a target of autoantibody. Hashimoto's thyroidosis, the thyroid protein and cells is a target of your cytotoxic T cells along with the autoantibodies. Idiopathic thrombocytopenia purpura. So the platelet membrane proteins are affected. Insulin dependent diabetes mellitus, as we were also discussing. It is because of the pancreatic beta cells becoming a target of cytotoxic T cells and autoantibodies. Myasthenia gravis, the acetylcholine receptors are target of autoantibody. Myocardial infarction is in the heart. Again, autoantibodies alone mediating this process. Pernicious anemia, we have just discussed. Post-streptococcal glomerulonephritis is in the kidneys. And the antigen antibody complexes is mediating the immune response that is getting mediated from the antigen antibody complex is because of the immune response coming from them. It is resulting into post-streptococcal glomerulonephritis. Okay. And eventually, if you have the sperm cells, which becomes a target of the autoimmunities, then it could also lead to spontaneous infertility. Now, the third type being systemic autoimmunity. Somehow did not be the table. These are some examples of systemic autoimmune diseases. So ankylosing spondylitis, where it's an autoimmune disease related to your vertebral column, and the immune complexes that remain persistent is leading to the production of autoantibodies. Similarly, multiple sclerosis, Th1 cells and Tc cells, along with the autoantibodies, are mediating the damage of the brain white matter. Rheumatoid arthritis. So, rheumatoid arthritis and systemic lupus erythematosus is the most studied examples of systemic autoimmunity. So, systemic, again, as the name suggests, it's multiple organs and multiple tissues in your body that gets affected. So, for example, in SLE or systemic lupus is the kidneys, the joints, the brain, the heart, everything gets damaged because of the autoimmunity that is being produced or because of the immune complexes. So immune complexes, wherever you are seeing this, is the hypersensitivity reaction mediated damage that is causing the faults. Autoimmune antibodies. So essentially, when an immune system starts to go haywire, it could go haywire at multiple instances. So there could be hypersensitivity that triggers the production of autoimmunity, because autoimmunity and hypersensitivity both results from non-specific or say exaggerated responses of the immune system. Some changes here and there is very much noted, and it is very common for us to find that hypersensitive reactions and autoimmune reactions are happening together in the same type of disease. Okay, and say for in rheumatoid arthritis, the most affected is the joint, the synovial membranes of the joint, but we can also have the effect in the later stages. We could also see that there's some muscle wasting, the subcutaneous tissues can have some damage. There could be some problems with the heart, so that's how they are classified under systemic autoimmune diseases, right? Because multiple tissues, multiple organs at the same time, with the advancement of these autoimmune diseases, get gets damaged. Okay. So with this, the only thing that you should remember for your immunodeficiencies is, as the name suggests, it is arising from poorly or the poorly functional or less or a deficient immune response that gets mounted. It could again result from two phenomena. One is your primary immune deficiency, which means that from the birth itself, you are born with some sort of deficiency in the immune system. So the deficiencies could be, say, if the complement system is deficient, if there's one or the other protein of complement system that is not getting produced, or if the phagocytic ability of the macrophages is deficient, or if we have the lymphocytes which are not properly mounting the immune response. Those are some of the examples of your primary immune deficiency. So if you remember, we discussed a case wherein very initial classes. So again, this for immunodeficiency, again you will have a table like this, wherein you might have to remember that which particular cell or which particular system of the body is having an immune deficiency, because of which a particular type of disease is getting manifested. I don't know how I missed putting up the tables here. But okay, I'll just add it and I'll upload it to the notes as you get the notes for today's class. So essentially, in your primary immune deficiency, there are three diseases that we commonly read about, which is your SCID, severe immune combined immunodeficiency. So it's your leukocyte deficiency that could be there. It could be some deficiency with your complement proteins, or it could be some deficiency in your phagocytic ability of the macrophages or the other phagocytic cells that are present in the immune system. Leuko of all of this, the lymphocyte deficiency is most critical, because so different lymphocytes, all of them, adaptive immune response is completely being compromised. And examples of it being SCID, Daijar syndrome, and Sheddick-Higashi syndrome. So in all these cases, we have, so for in SCID, we have very low circulating number of lymphocytes, because of which there is no much memory response that comes up. So the same pathogen can keep on causing a problem in the same individual. In DJOT syndrome, there is deletion of chromosome 22. Because of that deletion, the antibodies, there is complete inhibition of thymus, and so that in DJOT syndrome, it's your thymic cells that are compromised. So because there is no thymus, so all the T cells that was developing inside the thymus, this thing we have also discussed previously while we were learning about the development of the T cells, that if the thymus goes missing, the entire population of T cells is absent from the body. So in DJOT syndrome, because of the absence of thymus, the immunodeficiency of your T cell population results, and because of that, the disease is eventually getting a chance to manifest. So in Shiddak Hegis, okay, so these are very complicated names to pronounce. So Shiddak Hegishi. Higashi syndrome. So this is resulting from autosomal recessive. It's an autosomal recessive disorder wherein the phagocytes do have the active granules present in it, but the granules do not get a chance to degranulate, and eventually there is no killing or phagocytic clearance of the pathogen that can result from it. So this is an example of phagocytic deficiency. And the idea is the primary immunodeficiency is resulting because of some congenital defect, which means it is present since the birth. Secondary immunodeficiency is resulting because of some medical condition which is acquired after the birth, after the birth, say the HIV infection. So in HIV infection, what is happening? Your HIV virus is making the T helper cells its hosts, right? So eventually the number of T helper cells is going down. Because the T helper cell population is going down, all the effector response that was getting mediated by the T helper cell, that entire arm of immunity gets compromised. So this sort of immunodeficiency, which is resulting from some other underlying condition and the underlying medical reasons, that sort of deficiency is called secondary immunodeficiency, and it is something that is acquired and it's not very much present since the birth of an individual. So with this, I will let's just see if I can find that table right now. I'll put it in the notes and we can go through it. In the meantime, if there is anything that we can discuss further, so with this, I will finish off with the course syllabus. I think so. The lecture from last class, I think that is going to be very helpful. We tried to put everything in the context. We tried to discuss the different arms of adaptive and innate system, how the two things are overlapping. So we first discussed the adaptive immune system separately. We then looked into the innate immune responses, the overlaps between the adaptive arm and the innate arm. And the last class, we tried and discussed the innate immune effector responses, that is mediating all the immunological responses, right? So, three things which means overall you have to try and remember. And the adaptive system, the cells of it, the receptors of it, how it is developing, how it is achieving the tolerance components. Then you have to try and recall that what are the effector molecules of the adaptive immune system and how they are mediating or how they are talking to the effector response molecules of the innate immune system. So, wherein in this overlapping segment, we have the complement pathway, the ADCC or the opsonization pathway coming up. So, once your adaptive immune effector molecules are recruiting the innate system, from there we started our discussion that what are the effector responses of the innate immune cells, right? And eventually, in today's class, finally, we try and understand that if either of these arms are compromised or either of these arms start to malfunction, what all immunological consequence can come up. So that's like the broad headings under which you should try and recollect the topics. This was the list. If there is anything from any of the classes that we can discuss further upon, or otherwise we can close the session. And while you all, so Shamika, you are right here. So while you are preparing for your exams, if there's any other doubt that you come across, we will be available. So we, as in all three of the doubt clearing TAs that have been assigned to you all, you can get in touch with us through the groups, I think the drive, the groups that have been made on the drives, right? You can post the queries there and we'll be there to guide you. But yeah, today being the last live interaction, if there's anything that you would want to discuss.
Ma'am, opsonization and phagocytosis both means the same.
The opsonization is the phenomena wherein the so you remember about the haptens and adjuvants. Do you recall those concepts? So if there's an adjuvant, it is enhancing the phagocyt the antigenicity of an antigen, right? So something similar to that is opsonization. So what happens in opsonization is if there's a small antigen lying around somewhere in the circulation, the chances of your phagocytic cells to find it and clear it is somewhat lesser. But if I have my antibody complex, antibody molecules coating this antigen, it becomes a larger complex. So now it can be said that the antigen is opsonized. Because of opsonization, the ability of phagocytic clearance of this antigen is enhanced. So there are this is two different processes, one helping the other.
Okay, ma'am.
So when is the exam? It is when this is the only table that is present here. Anyway, so when is the exam for you all? Is it? I think it's 27th of October, right? Are you
Yes,
appearing?
ma'am. To 26 or 27.
Okay. Okay. Good luck with the exam. You will have the notes for the this class and the last class uploaded. And if there's any follow-up questions, you can always post it to the groups. So we can close the session if this is okay.
Yes, ma'am, definitely.
Okay. So all the best with your exams. You have been a very regular student to the class. I hope you do well.
Thank you so much, ma'am. It was a great pleasure meeting you during this course of duration.
My pleasure. My pleasure. Okay. Chalo. All the best, Tara. I hope to see you in some upcoming courses, maybe.
Thank you so much, ma'am. I too be missing you.
Okay. Okay.